everyone. We're going to give 1 minute for everyone to get settled in the room. My name's Terry Anderson. I'm the STI Training Manager for the Denver Prevention Training Center. Welcome to the monkeypox virus update. Okay, I think we'll go ahead and get started in the interest of time. Few housekeeping announcements. We will be sharing the slide deck with those that registered shortly after the program. We will also be recording, and in fact are recording this session, and that recording will be available as well. And then we appreciate if you would keep your audio on mute through the program until the end, and then we welcome you to unmute and ask your questions of the panelists, or even in the chat box you can use, and we'll be monitoring the chat box throughout this hour together. We have 3 short presentations today before the panel. Kathleen Satterfield from Colorado Department of Public Health and Environment will be discussing the history and current epidemic of monkeypox virus. Dr. Karen Wendell will be from Denver Health Medical Center, will be providing the clinical overview. And then Rana Bond from Colorado Department of Public Health and Environment will be talking about testing and processes.
That's a cool haircut.
A few resources that we wanted to make sure you were aware of. The Denver Prevention Training Center is one of 8 clinical STI training centers that's part of the national network of STD clinical prevention training centers. Lots of resources, so check out those websites. 2 key resources we wanted to make you aware of are our national STD curriculum based out of the University of Washington. There are 7 CE approved modules for learning and continuing to learn about STIs that are available to you, as well as we strongly encourage you to use our STD-CCN, which is our clinical consultation network. If you're managing a tough patient, need resources, please use www.stdccn.org and send your questions to us. They go straight to content experts at all the prevention training centers. And we'll get back to you on that. And then finally, a resource for those in the Denver metro area is our Denver Metro STI Coalition. And this is a terrific group of over 80 members of healthcare organizations in the Denver metro area that come together to tackle the rising rates of STIs across the Denver metro area. So today, we're going to review the history and epidemiology of monkeypox virus. We'll talk about the clinical presentations that we've been seeing currently. We'll review testing and treatment and outbreak control interventions. And then we're going to have a terrific panel that will be sharing some experiences and insights in identifying and managing monkeypox virus. So without further ado, it's my pleasure to introduce Kathleen Satterfield from Colorado Department of Public Health. Kathleen is a vaccine and preventable disease epidemiologist, and we're grateful she's here with us today.
Hi, Terry, can you hear me?
Yes, I can. Thank you, Kathleen.
Yeah, thank you for that great introduction. So I'm here to explain a little bit of background on the monkeypox virus. Apologies for the dogs in the background. The history of the outbreak currently, current epidemiology, international, national, and here in Colorado, and the transmission of the monkeypox virus. Note, the information in this presentation is specific to Colorado and doesn't apply to other jurisdictions. Next slide. So a little bit of background on the disease. Monkeypox is caused by the monkeypox virus, which is an orthopox virus. It was first discovered in 1958 when outbreaks affected colonies of monkeys kept for research. Natural reservoirs of the virus remain unknown, but it's probably rodents and monkeys. More common in humans since the eradication of smallpox. The smallpox vaccine is effective against other viruses in the family. So waning immunity might be a factor in the emergence of monkeypox. Smallpox was eradicated in 1980 and soon after vaccination stopped. Next slide. Currently, there are 2,500 plus cases in 37 non-endemic countries as of June 21st, 2022. Most of the cases reported through sexual health and outpatient clinics with travel to countries in Europe and North America rather than endemic areas. No deaths have been reported. Evidence suggests transmission may have been occurring for several weeks or more before detection of initial cases. Prior to 2022, we don't see any chains of transmission outside of endemic areas. Next slide. Monkeypox in the United States during 2022. As of June 21st, there have been 113 cases in 21 states, including the District of Columbia. It's more mild illness than in previous outbreaks. Atypical presentations, including localized rash and often no prodrome for some. Anyone who has been in close contact with someone who has monkeypox is at risk. Early epidemiological data on cases of monkeypox suggest an increased risk for people who have recently traveled to a country where monkeypox has been reported and or men who have sex with other men. Next slide. Here's a map of the states currently reporting cases throughout the US. Next slide. So a little bit on Colorado epidemiology. As of June 17th, we have 5 cases reported, 2 are orthopox positive and 3 are monkeypox positive. All have been in the Denver metro area. 2 cases traveled to a country with an outbreak and 3 are close contacts to another case. No hospitalizations and again, no deaths. Next slide. How monkeypox is spread. Through brief interactions with physical contact, without physical contact are unlikely to result in transmission. Spread by close contact with monkeypox rash, sores, or scabs from a person with monkeypox. Likely the most common type of spread in the US right now. Also contact with objects, bedding, or towels or surfaces. Respiratory secretions through kissing or other face-to-face contact. It can also spread through close contact that occurs during sex, whether it's oral, anal, vaginal sex, or touching the genitals, hugging, kissing, or massage. The virus can be transmitted when symptoms start until the lesions have healed and new skin has formed. Next slide. Some infection prevention. Transmission requires prolonged close contact and is rare in healthcare settings. None currently in the United States outbreak. The CDC and the Colorado Department of Public Health and Environment have guidance for infection prevention for healthcare settings, EMS, laboratories, home isolation, and disposal of medical waste. Links below. CDPHE works with healthcare facilities to conduct risk assessments for healthcare worker exposure, monitor their symptoms, and administer PEP. Continue precautions until all lesions have crusted over. Those crusts have separated and a fresh layer of healthy skin has formed underneath. Next slide. Healthcare prevention, or infection prevention, excuse me, and healthcare. Use standard precautions for all patients, including hand hygiene, PPE for anticipated exposures to blood and body fluids, and environmental disinfection. Place patients with symptoms of monkeypox in a private room with the door closed. Limit entry to essential healthcare workers. Use transmission-based precautions for suspected monkeypox, including gowns, gloves, eye protection, and an N95 respirator. Disinfect the environment with an EPA List Q product. Avoid aerosols from contaminated environment, for example, shaking out linens. Perform aerosol generating procedures in a negative pressure room. For guidance for disposal of, follow guidance for disposal of regulated medical waste. Next slide.
Thanks so much, Kathleen. My name is Karen Wendell. I'm sorry, could you not hear me before, Terry? Okay, sorry. My name is Karen Wendell. I'm the medical director for HIV/STI prevention at Public Health Institute at Denver Health, and I'm going to go over the clinical presentation of monkeypox. Next slide. To begin, I want to make sure everyone's aware that some of the data that we got early on was really referencing classic clinical presentation of monkeypox that's been seen in Central and Western Africa, and as contacts directly or travel to that area. And what we're seeing now is somewhat different. So to be clear, that classic presentation typically has an incubation period between 5 and 21 days, but most folks presenting between 7 and 14. That still holds true now. But typically there is a prodrome that precedes the onset of rash, anywhere from 1 to, at the outer limits, 4 days prior to rash onset. And the characteristics of that prodrome are fever, malaise, headache, lymphadenopathy, and sometimes complaints like sore throat. And then a rash begins. And typically all the elements of the rash follow together synchronously, meaning that initially you may just have some areas of macular erythema progressing to papules, then to vesicles, pustules, and scabs, each of these over several days' time. But in the classic presentation, you wouldn't have a patient presenting, let's say, with papules and also with pustules and scabs. They would be all at one stage of their rash development. And as was stated before, we consider folks contagious from the very onset of symptoms. And so in the classical phase, this would be in the prodrome, to the point that the scabs, which can contain live virus, have fallen off and new skin is formed over that. Next. So we're seeing something different. This new presentation of monkeypox really flew under the radar, likely for several weeks, resulting in transmission across multiple countries internationally. And what we're seeing is that many cases are presenting without those classical clinical pictures. So many folks are not having the prodrome. And when we talk about the rash, we usually in monkeypox think that it would begin in the face and in the extremities. This has not been typically the case in what we're seeing now, where we have seen patients who have had atypical lesions, like 1 lesion or 2 lesions, yet have monkeypox. They have had initiation of the rash in genital or perianal regions instead of at the face and extremities, and then have progressed to dissemination. And very notably, we've seen asynchronous stages of the rash. In other words, seeing vesicles at the same time that we're seeing crusted lesions or papules. And then seeing some folks who get the prodromal symptoms right in the middle of disease. And very notably, and something that I want to make sure everyone on the call is aware of, many of these cases have presented with symptoms of very severe proctitis. And at the time of presentation, haven't necessarily had noted ulcerations or lesions. And so when we're seeing folks with proctitis, this also needs to be in our differential. Although we've not thought of monkeypox as being typically sexually transmitted, any process that can result in close skin-to-skin contact certainly can lead to transmission of monkeypox. We really don't know the role of semen or vaginal fluids at this time, or how long live virus may remain in these types of tissues or excretions. Next slide. So this comes from an MMWR report that was released in June on the 10th and describes the first 17 cases that we've had in the United States that were from 9 different states in US. And what you can see is the variability of presentation. So the red dots are the time of fever onset. The green dots is the rash onset. And then the blue dots is when we made the diagnosis. So unfortunately, you can see that diagnosis is anywhere from right at the initial presentation to out to about 21 days. The average time to diagnosis after rash onset was 11 days for these initial 17 cases. And we're hoping in the future we can do better with this. But as we've seen in Colorado, it's been challenging, and we've had a very similar experience to this thus far. Only 12 of the 17 cases did report a prodrome. 8 had their rash begin in the genital region. 16 did develop dissemination. So we, even in the cases that we've seen here in Colorado, have had at least one patient where it was unclear if they disseminated or if the lesions remained only in that genital region. 16 identified as men who have sex with men, and the range of ages was between 28 and 61. In those initial 17 cases, there were 3 folks who were immunocompromised, and of those 17, only 1 received treatment with ticagrelor, which is an antiviral that the CDC can make available for severe cases. Next slide. This is a little more data on what symptoms look like and frequency of when they were seen. So the first column here gives you if it was seen in the original prodrome period or if it was seen at all during the entire course of illness. So you can see that some of the other common symptoms that patients complain about are fatigue and malaise at 76% or chills in 71%. Only 53 had lymphadenopathy. We think of that as a very prominent symptom for monkeypox. And you can see that cervical lymphadenopathy was far less frequent than inguinal adenopathy, seen in 35%. And then you can see for rash location, perianal region was present in 35% of those initial 17 cases. Arms and trunk were involved in over half. Next slide. So on the next several slides, I'm going to be showing you many pictures because I want you to have these in your head as you're looking at patients and thinking about whether you should be sending monkeypox testing. And you can see that there's a variety of appearance. And so as you look through these panels on the upper left, you can see that instead of looking erythematous, it looks hyperpigmented, papular. Maybe some of these have some central umbilication, and so people with darker complexions may have less of an erythematous appearance. It absolutely can involve hands and feet. We're in the middle of a syphilis epidemic. These 2 etiologies should be in your mind when you're seeing palmar and plantar, in addition to things like Coxsackie virus. And then you can see a frankly pustular lesion here on the thumb, and you can see how the lesions can ulcerate and leave these central craters. And in these sections F and G, you can see how they can look very much just like fairly innocuous papules that may just have a very small central pustule. And then finally in F, this patient actually had an abscess that was thought to be caused by the monkeypox virus with significant pus formation, and this was a deeper structure. Next slide. So here too, to give you a few more pictures just to keep in your head, I will say that the 2 cases that I've seen had lesions like the upper left with a vesicle on top of an erythematous base, papule with a small pustule as you see in the center, and then on the right-hand side, that central umbilication. This can progress over to this crusting and necrotic appearance to the center that you see in the following 2 slides. And then finally, as they're healing, they'll get this kind of scaling lesion at the area where they had a lesion. Next slide. These are additional examples that were in the New England Journal, and you can see vesicles and erythematous papules that are present here, involvement of the hand. And in this case, there was also evidence of inflammation, gross inflammation and edema at the rectum and anus, with some superficial erosions and purulence, as you can see on this anoscopy. So very important, we say this all the time when we're looking at patients who are complaining of rectal pain or discharge, that we do that internal anoscopy and make our full considerations of differential, but really let the findings on anoscopy help us understand what is in the differential, because it will narrow things down a bit if you have ulcerations present. And in this case, for monkeypox, we'll give you an area that you could actually sample if there are no external lesions. Next slide. Here you can see that this patient in the upper left had macular rash along his thigh at the same time that he had an ulcer on his penis and vesicles and pustules on the dorsum of his penis. So he had a full range of rash present at that time. And then in panel C, you can see ulcerative lesions with exudate, fibrinous exudate, also seen in panel D with the necrotizing kind of scabbing, crusting changes that you see there in the perineum. Next slide. So what makes this so challenging is that we're in the middle of an STI epidemic with chlamydia rates up 1.2% since 2016, gonorrhea rates up 45% since 2016, syphilis rates up 52%, and unfortunately congenital syphilis up 235%. And so these can look very similar and have a lot of overlap with monkeypox. And the CDC wants us to know that many of these patients have had not just one diagnosis, but multiple. So diagnosis of STI at the same time as having a diagnosis of monkeypox. So we need to keep our minds open and send really extensive STI testing when we're evaluating someone who has risk factors for STIs. Next slide. So how do we think about the differential? And I just want to point out, I'm only going to be talking about the infectious differential. I'm not going to be talking about non-infectious etiologies at this time. When we're thinking about the rash, many of the presentations could be herpes, primary or secondary syphilis, molluscum contagiosum, lymphogranuloma venereum, which often presents with ulcerated lesions and very impressive lymphadenopathy, varicella zoster, either as primary infection or in shingles, disseminated gonorrhea, disseminated fungal infections. And for proctitis, we most often keep in mind gonorrhea, chlamydia, herpes, lymphogranuloma venereum, and syphilis. But again, there can be other etiologies of these presentations. So for instance, looking at that left panel, we have an purulent lesion with a central necrosis on an erythematous base, and that is not monkeypox. That is disseminated gonorrhea, and you bet they'll have prodrome symptoms because they're going to have fevers and chills. And this patient would need to be admitted and put on IV ceftriaxone. So we need to keep those things in our differential. Herpes simplex and syphilis changes, as you see on the top, and then molluscum, which might be one of the easier ones to differentiate because typically all of those will look exactly the same, and the client often will tell you that they've been present for weeks and weeks. Monkeypox will evolve, and so to have these central umbilicated papules present for weeks and weeks without any other symptoms helps you figure out molluscum versus monkeypox. Next slide. How do we manage these clients? We do want to think about who's at risk for developing severe disease, people that we might think could be candidates for antiviral therapy, immunocompromised individuals, women who are pregnant or breastfeeding, persons who are less than 8 who might be household contacts, persons with underlying disseminated skin disease, extensive psoriasis or eczema. Reasons for admission that have been seen thus far are secondary bacterial infections of lesions. It can progress to encephalitis and can have a hemorrhagic form and it's extensive disseminated disease. But primarily what we've heard about from other countries has been admission for pain management, specifically for the proctitis that has been seen with this process. Next slide. So how do we deal with this in the clinic? I think you want to make sure that you're screening early so that you can put a patient in the proper location and get on your PPE. So you want to ask at entry into the healthcare system if they have any symptoms, and we ask about COVID symptoms as well as monkeypox symptoms. And if they have them, we'll put them into isolation. If you can use a negative pressure room, that is preferred if you're going to be doing aerosolizing procedures. In our clinic, we just use a regular private room and close the door and then initiate our PPE. Next slide. Currently, the CDC recommends that for PPE, we use full coverage with a gown, consider an N95 versus a droplet mask. Wear a face shield to protect the eyes and gloves. And so that is the current recommendation for PPE. Next slide. So I'm going to go ahead and turn this back over to our colleagues from CDPHE. Rona Bond is going to be our next speaker. She's an epidemiologist with the Vaccine and Preventable Disease branch at CDPHE, and she'll be talking to us about testing, treatment, and outbreak control. Thank you, Rona.
Hi, thank you. Can everyone hear me?
Yes.
Super. Next slide, please. So as Dr. Wendell said, I am another epidemiologist in the Vaccine Preventable Disease program at CDPHE, and I'm going to be talking about a few of our elements of disease control today, including who we recommend for testing, our testing criteria, specimen collection and transport, what happens when we have a positive result, contact tracing, resources for PEP and treatment, and also resources available on the internet on our state website. Next slide, please. First, it's important to know that orthopox testing is only available through the Laboratory Response Network, not available through any commercial or hospital laboratories. This means that the laboratory testing is performed through a cooperative agreement with CDC and is used to determine the presence of non-variola orthopox virus. Orthopox positives are sent to CDC for confirmatory monkeypox testing. And all of this means that pre-approval is required prior to sending specimens for testing. Next slide, please. So how do we do that part, the pre-approval? First, a Colorado healthcare provider calls us to discuss testing options and recommendations. We use clinical information about patient symptoms and risk factors to determine the need for a test. And then we go over specimen collection and isolation guidance. Swabs of the lesion or rash are sent to our state laboratory for orthopox testing. The results are available within 48 hours. Positive results are called directly to the provider, and negative results are sent via email or fax. All positive orthopox specimens are sent to CDC for monkeypox testing. Patients being tested for monkeypox should be told to isolate at home. And we'll talk a little bit more about that in a moment. Next slide, please. So who are we testing? We are testing anyone with new onset rash or lesion and recent contact with someone with a similar rash or was diagnosed with monkeypox, or close or intimate contact with people in a social network experiencing monkeypox cases. In this case, this includes men who have sex with men, or traveled outside the US to somewhere with confirmed cases of monkeypox, or had contact with wild animal or exotic pet from an area where monkeypox is endemic. Next slide, please. For specimen collection, the preferred specimen is a dry lesion swab. We need a minimum of 2 swabs from the same lesion for both preliminary and confirmatory testing. The CDC can now accept lesion swabs in viral transport media and lesion crusts, though these specimen types must be received by CDPHE within 24 hours of sample collection and forwarded to the CDC laboratory within 7 days of collection. Universal transport medium is not acceptable at this time. All specimens should be stored at 2 to 8 degrees Celsius or less than -20 within 1 hour of collection. Next slide, please. So when somebody tests positive, we ask them to isolate at home, staying away from household members, pets, not going into work until all lesions are completely healed. That means even past the crusted over stage, until new skin has formed over the places where lesions had once been. Antiviral medication approved for smallpox treatment may be indicated for patients with certain underlying conditions or clinical presentations. These might be accessible via consultation with CDC via your state health department. A public health interview will ask about travel, close contacts, and medical visits. This interview information is, of course, kept confidential. Next slide, please. So our contact investigation process is pretty extensive. After a case is identified, or sometimes with a highly suspicious case prior to test results, we'll talk to the patient to assess social and healthcare contacts during the case's infectious period. It's important, it's so important, of course, for people to answer or return calls from public health so we can actually conduct this investigation. Healthcare facilities who treated a monkeypox case are contacted by our healthcare associated infections team to assess exposures among healthcare staff. When assessing someone suspected of having monkeypox, gathering names of staff treating the patient will make assessing exposures much easier if the patient does eventually test positive. Next slide, please. Contacts are categorized as high, intermediate, or low risk based on type of exposure. High risk exposures include sexual contact and in handling infected linens with non-intact skin, and healthcare workers in a room during an aerosolizing procedure without an N95 mask. Intermediate risk includes being within 6 feet for 3 or more hours without a mask, or with a mask and face shield, but without a gown. Low risk contacts include briefly entering a patient room or any healthcare workers using full appropriate PPE. Identified contacts are monitored daily for symptoms for 21 days after last contact with the case. And contacts with high and intermediate risk exposure are also offered post-exposure vaccination. Next slide, please. Tell me more about this vaccination, you say. Okay. Post-exposure vaccination is currently only available through state public health. Vaccination may prevent monkeypox infection or may make illness more mild. It's best to get vaccine within 4 days of exposure, but it may be helpful up to 14 or maybe possibly even more days after exposure. Pre-exposure vaccine is only available to those with occupational exposure. For example, our laboratorians in state public health who are actually conducting the orthopox tests. Next slide, please. So there are currently 2 vaccine products available from the Strategic National Stockpile, a single-dose vaccine and a 2-dose vaccine series. CDPHE has ordered the 2-dose vaccine series Jynneos for vaccination of intermediate and high-risk healthcare workers and social contacts following exposure to monkeypox. We coordinate transfer of doses to partners for first and second doses and ensure vaccine documentation within the Colorado Immunization Information System. We assist partner organizations with vaccine administration and documentation as needed and ensure dose level vaccine accountability. Next slide, please. There are also antivirals available, though most individuals have mild self-limiting disease that don't require treatment. Prognosis depends on multiple factors, including previous vaccination status, initial health status, and concurrent illness or comorbidity. There are 2 treatments available in the Strategic National Stockpile, and one of which, the TPOXX, is under an IND. It is FDA approved for smallpox, but not monkeypox. Next slide, please. Colorado's response to monkeypox has been varied and multi-leveled. So in disease control, we coordinate and perform orthopox testing. We conduct case investigation and contact tracing, monitor close contacts for 21 days after exposure, and do the ordering, distribution, and tracking of vaccine. Our communications have included infection control guidance for healthcare settings and provider outreach and messaging, primarily via HANS. We submit press releases and respond to media inquiries, and we are active with community outreach and engagement. Next slide, please. We also have a pretty amazing website up for monkeypox that has links to a lot of information and some really great resources. It includes clinical resources, including testing guidelines, infection prevention, and guidance for clinicians in a few different settings. It also includes some of our epidemiological information, including current case counts, risk determinants, and frequently asked questions, and links to external guidance, including training materials. Next slide, please. Our education and outreach efforts, I'm proud to say, began immediately and continue to this day. We host roundtable meetings with community-based organizations and Denver area gay bar owners and operators. And we have had and will continue to have presence at at Pride festivities. We did over Juneteenth, and wherever we can set up a table and have materials. We increase community outreach via posters, printed materials, digital ad buys on apps and websites. We're really getting the word out there as best we can. And that concludes my slides. Thank you for your time, and we're happy to answer any questions.
Thank you so much. And so here we have a list of resources, and as Terry said, we'll be distributing the slide set, and you'll be able to take a look at some of the resources that are available, and encourage you also to visit the CDPHE website on monkeypox. I now want to introduce some of the members of our panel and thank them so much for joining us. With us today, we have Ed Gardner, who's one of the infectious disease physicians at Denver Health and the director of the Center for Positive Health. Kelly Hawkins, who's another ID physician here at Denver Health. And Gabby Frank, who is a hospitalist and medical director for the Denver Health Biocontainment Unit, as well as a faculty member for the Region 8 Mountain Plains Regional Disaster Health Response System Training Center. And then, of course, Kathleen and Rana are still with us to answer any questions that we have on logistics and transmission and post-exposure prophylaxis. So thank you to our panelists for joining us. There were several questions that already came in across our chat that I want to throw at you and let people chime in, and keep throwing them in there. I think Terry's going to man our chat a bit and help me out. But I want to start out, there was a question about what do you do if you have someone come in with proctitis, you evaluate them, you don't see any lesions. I'm assuming this person was including an anoscopy if you don't see ulcers there, because you could sample an ulcer if you saw it on anoscopy, or if you saw an oral ulcer, you could sample that as well. And I'll welcome CDPHE to tell me if I say anything wrong as we speak. But Kelly and Ed and Maria, Gabby, what other things would you do? So you see them, they don't have ulcers, you're evaluating them for proctitis.
So I think that we really need to keep monkeypox in the back of our mind with all of these patients. Without lesions, of course, at present, there's no way to test. So in a patient like this, I would go ahead and test for other STIs, gonorrhea and chlamydia, syphilis, and then swab, probably do a blind swab for HSV and rectum. And if all of those come back negative, even if one of them comes back positive and the patient have symptoms, this is something that we would bring back within 5 to 7 days. At that point, we would expect some lesions to develop. I would repeat endoscopy, internal, and then go from there.
So Kelly, your audio is breaking up a little bit. I think, I'm not sure if mine is also breaking up. We might want to, it's not, okay. We might want to have you call in.
Okay.
Maybe it's your computer.
Will
Okay.
do.
Ed, do you have anything to add?
Well, I was going to ask Kelly a question to set her up, but one tidbit, interesting thing we found was on 2 different HSV cultures, we were told that there was a cytopathic effect, like a virus was present, but the culture was negative for herpes viruses. A lot of us do PCRs for herpes testing, but you can do cultures. And I'm not making a recommendation for one or the other, but if a culture is done and there's something that's wrong with the culture that looks like a virus is present and herpes isn't found, that should really raise level of suspicion.
And I just wanted to add, like I think that the majority of the patients so far have been all outpatients and have not been hospitalized. But when you think about patients in the inpatient setting, there may be patients that are immunosuppressed because they have a transplant or they have HIV or they're undergoing chemotherapy and they come with a fever and sepsis, and those patients get hospitalized. And I think that because of the current presentation, people in the inpatient setting are not necessarily thinking of monkeypox in the differential. I think it's very important to keep monkeypox in the differential diagnosis and ask all the questions. And again, when the patient comes to the inpatient setting, people get caught off guard and maybe they're not doing an endoscope exam or they're not doing a genital exam. And it's very important to highlight, to take a good history, to be able to get that light bulb and go to do the exam maneuvers that will help us decide if we need to go with more questions or maybe call CDPAG and consider testing. Because again, most of the presentations are being mild and they're being handled as an outpatient, but I think that we're setting up some inpatients provided for failure when we're not thinking about it. And some patients with risk factors will get hospitalized because of like sepsis as a big diagnosis and a big umbrella. And we need to be very cognizant that monkeypox is going around and take a good history.
I think these are great points because we know that definitely in the UK, they've seen significant admission rates because of the proctitis and the pain. So we need hospitalists to be very aware of this, EDs to be very aware of this. And I think as it's outlined by the panelists already, you know, if you see someone like this and there isn't a lesion, you want to, you know, be doing your empiric treatment for proctitis, sending off, you know, the broad testing that we do for proctitis, but then also empowering the patient. If you start developing a rash or lesions, or if this doesn't get better rapidly with this empiric therapy, we need to reevaluate you. And so for our own sexual health clinic, part of that process is looping back to them in a day or two and really following up on that. I think it's, you know, notable that for some of our cases, they were very mild presentations. And one of the patients I saw, he had 2 papules on his arms and the rest of the lesions were on his back. He didn't even know they were there. And so when we're evaluating these clients, we need to do a really thorough skin examination. Okay, so people are asking about, gee, you know, they had some cases that presented late April, early May, and now the patient's fine. Is there a way to be looking for monkeypox in these folks? Can we get serologies? And I know there were some answers in the chat, but wanted to open that up to our panelists.
I'll contribute, and maybe our partners from State Health know more. You know, in talking about some cases we're evaluating today, we've been told that the serologies are really being offered for people who have kind of borderline or inconclusive preliminary results, and we don't have a good way to follow whether they're actual cases. But CDC is considering offering their IgM and IgG in other situations. But right now, I'm not sure that this is widely available to check a serology. And if that's incorrect, maybe someone else out there knows.
I was going to say that, yeah, no, the CDC has the presence of IgM and IgG as part of their confirmed cases or like, so it's like it's part of their case definition in a way. So, but I don't know exactly how available it is to our patients.
Emily from CDPHE added into the chat that at this time CDC is accepting serum specimens for monkeypox testing, only available for patients who are orthopox positive, but couldn't be confirmed as monkeypox. Okay, well, so I wanted to ask some of our folks who've actually seen some cases, Kelly and Ed, what was the course like for your clients? What was the variability of it? Did you consider antiretrovirals, and what did you learn about antiretrovirals?
Okay, neither of us are, Kelly, you want to go?
Yeah, I'll go. How's the audio?
Looks good.
Okay. Good thumbs up. I'll talk about two of the cases that I got to know the best, and they both presented with proctitis. And you know, the first case presented really before we knew too much about monkeypox, and he had several encounters with the healthcare system prior to being diagnosed. And I will say that in this case, he presented with severe proctitis prior to having any lesions. So kind of the case that we've been considering. And all of his testing was negative. He did have a prodrome of kind of chills and myalgia. He had a very sore throat. All of his STI testing was negative. His HSV PCR was negative, and then at a later time, his HSV culture did show this indeterminate cytopathic effect that is now very curious to us. And over time, as his proctitis was resolving, he developed lesions that were asynchronous, as Dr. Wendell described. And he had both kind of peripheral lesions and perirectal lesions, and probably had lesions in his rectum as well. He took about a month to fully get over his symptoms, for his lesions to scab, and for new skin to grow over. So he had quite a prolonged course. The second case that I know best similarly had proctitis with prodromal symptoms. And this patient, his time course was, his total disease course was more close to like, I would say 14 to 18 days. So a little bit shorter, but still quite prolonged. And very similar presentation to the first one.
I'll throw in a case that I saw that was a little different. I had a person with penile lesions, had no prodrome, and had multiple lesions at different stages, including one more that came up after his initial exam when I saw him. And he was of an age that he received smallpox vaccine as a child. There is some data out there on classical monkeypox that receipt of smallpox vaccine, even decades before, can minimize or prevent disease. I didn't know if that maybe made his course a little milder, but he had no prodrome. And I saw him, he had lesions for 3 days when I saw him, and I saw him 7 days later, and they were 100% healed. There was new skin on every lesion 7 days after my initial exam. And so it was very surprising. We did have a conference call with CDC about him because he was a contact, so we knew his infection was really new. And we talked about tecovirimat and opted together, since the symptoms were so mild, that we didn't think it was warranted in the case. And looking back, I don't think it was. But CDC and state health are very quick to get on a phone within an hour sometimes and have a group conversation to go over the cases case by case to discuss treatment. I thought that was very helpful.
I'll just add really quickly, and Dr. Wendell, feel free to chime in, but there, another case that we evaluated here, specifically Dr. Wendell evaluated, the presentation was much less distinct, I would say. Had just lesions on the torso and the extremities, no genital lesions, maybe had some mild prodromal symptoms. But I think we're seeing a lot of heterogeneity in presentation, which leads us to believe that we really need to be thinking broadly when it comes to testing for monkeypox. The other thing I'll add is that it was determined that the patients that I was involved with, that they were too far along in their disease course to think about antiviral treatment.
What do we know about how those antivirals perform?
We know.
Yeah.
Go ahead,
Go ahead. No, I was like, there's only one like for this, not for the typical monkeypox going in Nigeria, but they tested this an old study, and it's like a very small study, 7 patients, and they tested brimcidofovir for 6 of the patients, and only 1 got tecovirimat, and they compared that the viral loads for the patient on tecovirimat went almost down to 0 at day 1. But it's only 1 patient, and the ones with brimcidofovir actually did not do that well. However, we currently don't have brimcidofovir available in the US as an oral form. We have it the IV form. And so it's like, there's not a lot of testing out there going on. And also the fact that the viremia reduces doesn't mean that the patients are less contagious, because there's no studies testing the presence of virus in the skin lesions. But if a patient is immunosuppressed, and again, I'm gonna approach this from the inpatient provider, which is usually the cases in which either the patients have other risk factors for getting severe disease, or they actually have severe disease, in which case probably we would want to try to start the patients on tecovirimat, and it's usually a 24-hour turnaround to get it. But again, before you start it, you're going to have ID involved in CDPHE, and there's going to be a call to make the decision. At Denver Health, with that, we have cidofovir available, but just to bridge to tecovirimat.
I'll just add that unfortunately, maybe for all of us, this can be spread to many different animal species. But fortunately for drugs, there are therefore animal treatment models where tecovirimat and brimcidofovir and these medicines are very effective at lowering viral load and preventing severe disease. So there's limited data. I think that's the best we can do. Yeah, I think Gabby already reported on pretty much the only human data that we know of, apart from healthy volunteers who tolerated the medicine very well. Those are the only other things we know about it, about tecovirimat.
Thank you so much. And then one of the questions in the chat was, for these patients that complained initially of proctitis symptoms, had all of them reported receptive anal sex?
The 2 cases that I described did report receptive anal sex.
Yeah, I think that's generally what we're seeing. I wanted to ask, for when you're managing these patients, what do you do for follow-up? How are you following them when you're trialing them, they can't leave the house? How have you managed them to discontinuation of isolation? What were the lessons you learned?
We've been doing a lot of phone follow-up during the early stages of recovery to see how people are doing. At least 2 out of the 4 had new lesions during their phone follow-up, but clinically remained very well. But we are seeing people back to clear them for return, so that we can make sure that the lesions have resolved and there's new skin there. And so some of that has taken a while. One of Kelly, I know we all know each other's patients. One of Kelly's patients was seen maybe 5 times to get cleared. And so it has taken a while, and some people, again, mine, the second visit a week later was cleared. Very variable, but close phone follow-up, and then physical follow-up until everything's resolved.
Thanks so much. And I think another question that came in the chat was, can a person with monkeypox transmit it to their household animals? And I think that really opens up questions about, what do we tell clients after we've made this diagnosis? What are the specific instructions for being at home? It's not just being at home. What other unique counseling messages are we to deliver as providers, and that get delivered by DIS and CDPHE? And I'll start with the clinical folks. Kelly and Ed, go ahead and tell us what you told your clients to do. Then I'd like the CDPHE folks to chime in about how they're managing this for us.
Oh, that sounds great. I'm sure CDPHE has a lot to add. For our patients, with confirmed orthopox or monkeypox, we are asking them to isolate at home. And obviously this is an easier thing to do if they work remotely and don't have roommates or don't have other household contacts. If they do have household contacts, we are advising that they isolate as much as possible. They wear a mask. And then we're especially worried about the issue of fomites and bedding, linens, clothing, towels, being modes of transmission. And so advising that anything like that is not shared and is washed as best as possible. And then we are concerned that there could be transmission to pets. And that is actually, I think, a big concern at the level of the CDC, and are asking that people stay away from their pets as much as possible as well. If people absolutely need to leave, we are advising that all lesions are covered and that they wear a mask at all times. I don't know, Ed, what else?
The only other thing, because that was fantastic, is if people are using bandages, disposable bandages, they really shouldn't go into the garbage stream in the community. And so we're asking people to bring them in. These have been very small lesions, so we haven't actually dealt with this too much. But we're asking people to bring them to a healthcare facility for incineration through our sterile processes. And that's because CDPHE and I looked this up when the first case was there. They found evidence of vaccinia can remain alive in the environment for months, plural. And so if that's sitting in a garbage stream, other people could be exposed, or even worse, maybe, or just as worse, animals could be exposed to it in a garbage stream. And so we're having people bring those in.
Thank you
I'm
so
so glad you
much.
brought that up, Dr. Gardner. These actually have been two really hot topics since the beginning of this whole monkeypox adventure. We're still working out specifics about how to handle household waste, but yeah, that is exactly some downstream effects of hazardous waste disposal. As far as pets go, what I think is really interesting is we don't have much data or information on non-rodent transmission. And I think it's important to note that negative or the lack of data does not indicate that there isn't the transmission, because I don't know that we've had much of a monkeypox presence in areas that treat pets the way we do. So pets in your bed, pets in your life up close and personal might be a different situation than how people interact with their pets in more endemic areas. So the short answer is we don't know. And the slightly longer answer is we are asking everybody to maintain distance between their household members and anybody who's positive with their pets, which I know can be tricky.
Rana, I was wondering if you could say a little bit about how a client is instructed to disinfect their home and their clothing and their bedding. Do you have to wash it in bleach? What do you have to do?
So right now, our understanding is that normal washing precautions are just fine. Throw it in the washing machine. That should take care of your linens and towels. As far as other household precautions, we did have a case that had some questions regarding their hot tub and having been in their hot tub with lesions. So we explored that a bit. There is a recommendation for cleaning it out, emptying the hot tub completely and cleaning it out. But other than that, we don't have a lot of constant cleaning that we're recommending.
Could you tell us a little bit about what has been done to date and what's recommended for household and sexual contacts, close contacts, and this concept of ring vaccination?
Well, we offer, like mentioned in that one of those slides about those tiered risk group of contacts. So we do offer post-exposure vaccination to those in the intermediate and high risk groups. I don't know, Kathleen or Emily, if you're in chat, if you can correct me, please, if I'm way off on this one, but I don't know that we have completely pursued a full-on ring, but we definitely do offer vaccinations, and some people have taken us up on that and some people have not.
How have you been managing folks that are living with other people in the home? And are you following up with some of those high-risk folks for that 21-day incubation? What are the recommendations regarding flights and other travel?
So again, we do, those risk group tiers really are helpful. And so some of our household contacts, I believe we're saying, you might be low risk, we'll just monitor you, but we are monitoring all social and household contacts for 21 days post-exposure. So we've recently, for example, had a few household contacts that developed possibly prodromal symptoms. So they're going in, was it yesterday, Kathleen, that they went in for evaluation today?
Today, actually. But
hot off the presses information.
Yeah, it was today.
So we monitor pretty closely. We have a pretty intensive monitoring process, and offer vaccination when those tiers describe a higher level of risk. And what was the second part of your question, Dr. Mendel?
Travel, if you've been exposed.
So at this point, we aren't, again, Kathleen, Emily, correct me if I'm wrong, but we aren't necessitating quarantine for travel, for contacts.
Oh, Rana, actually,
I'm off.
I'm so sorry, Rana. Can you guys hear me?
Yes, we can.
Rana, can you? Oh, okay. So I do want to say that we have gotten some guidance from CDC, which I don't know that they have put this on their website or not yet, but folks who are deemed high risk contacts are not supposed to long distance travel via commercial conveyance, i.e. airplanes, cruise ships, stuff like that during their monitoring period. It's more of like a shared decision making for those intermediate contacts, but for those high risk contacts, travel is not indicated, shall we say. So that might be important to know. But yeah, again, no recommendation for quarantine as long as folks are asymptomatic and well, but they are provided with instructions to isolate immediately if they develop any symptoms, even non-specific symptoms during their 21-day monitoring period.
Thank you so much. I know we are over time. I appreciate all the folks that have hung with us. I know there were some cases that were thrown into the chat that we didn't have time to go over. I would strongly recommend that you go ahead and enter those into the STCCN Warline consultation system, and we will absolutely look those over and give you a written response and recommendations. So please do that. And we did put the link in the initial PowerPoints. I am going to wrap it up with the last question to see if anyone knows the answer. If someone has monkeypox and does well and survives, and I do want to stress that I am unaware of any deaths outside of the endemic zones of monkeypox this year. They have had, I think, approximately 70 deaths, but I'm not aware of any deaths from monkeypox in the outbreaks that have occurred in non-endemic countries. If anyone's heard anything new, please let me know. So folks are having, relatively speaking, mild disease. How long will they be immune? Can they get this again? What do we know?
Well, if I don't know if no one's going to grab it, you know, this is.
Dr. Oh, go ahead.
Go ahead.
No, I apologize, Dr. Wendell. I was just in a session yesterday at the conference I'm at where we were discussing, you know, kind of what is the data about reinfection, and sort of the TLDR version of that is we don't think it is common. We don't have a lot of good data because of where previous cases have commonly occurred. So we don't think, we don't have data to suggest right now that it's like COVID, you know, where you could be an unlucky bug and get it twice in like, you know, 12 months or something like that. but we don't have a lot of data. So I think that's where we are, at least based on the conversation I was in yesterday.
Terrific. Is this Emily?
Yes, sorry, I'm in a car on the way to the airport.
Okay.
And I think real quick, if we have a second, I think Kathleen wanted to address the testing approval question that was in the chat.
Oh,
If that's
great.
okay,
Yes.
if that's not, we can follow up later.
No, please do.
I'll toss it to Kathleen.
So at this point, we have been lucky enough to have some of our call center colleagues help us out, because I know there was a bit of some roadblocks initially because there was only so many people who could approve testing. So the call center has stepped in to help us with approval for testing, and then they can send us questions if there's, you know, a strange presentation and we're not quite sure. They'll send us questions and then we can approve, but we're always in communication with them. And it, from the time they've come in since last Wednesday, it's definitely sped up testing approval, but it is a call into CDPHE and forwarded to the call center. And then after hours, it's the after hours epi who takes the information and then passes that information on to us for approval for testing.
Thanks so much, Kathleen. Ed, did you want to add anything about immunity?
I was just going to say, you know, there's pretty good evidence that smallpox vaccine, even decades prior, can prevent infection. And so I agree with everything that we don't know the answer, but it seems like it's a vaccine preventable illness, and that vaccine durability seems pretty long. So, you know, I don't want to be an over optimist, but just from an infectious disease point of view, I think there's probably evidence that rapid repeat infections would be uncommon, except in an immunocompromised patient who maybe couldn't mount an adequate response. But I think hopefully that's correct, and I'm not steering everyone wrong.
Thank you so much. So I want to thank all of our presenters and panelists, and a big shout out to Terry Anderson and Kim Taylor, who put this together in very short order, and to our CDPHE colleagues who have been under fire, but at request came to this webinar and helped put together a great presentation. So thank you so much. And I do want to say this is going to be recorded and many people will be looking at it after today. And I want to call out that the information is changing super fast. So please update yourself on CDC and CDPHE's website. Thank you so much and have a great day.
Thank you, Karen.